We will be going through the videos to see how intraop OCT microscope helps you to see the unseen. And basically, in the same eyepiece, you have the intraop picture, the surgical field, as well as the intraop OCT microscope, which is actually present at one end. So as you're operating, you can see this also. So you can see that the side ports have been made, and as you make the side ports, these can be seen here. And then subsequently, the main wound is made, whether you make it uniplanar or you make it multiplanar again, can be seen here. And as you make the capsulorhexis, when you focus on the lens, you can actually see the flap, which is there of the capsule. And this may not be of relevance, especially in corneas which are clear, but becomes of relevance when your cornea is a little hazy and you lose the edge of the rhexis, so you can actually see it here on the intraop OCT microscope and pick it up again. Now, after doing the capsulorhexis, you do hydrodissection, and as you do hydrodissection, again focus on the lens, you can actually see a fluid wave which will go in between the posterior capsule as well as the cortex. And also the hydromaneuvers can also be likewise seen. So as this hydrodissection wave comes behind the nucleus, one can see it. Then you have the hydromaneuvers, and as you make the crater, you can actually see the depth of the crater. So by looking at the sides, you actually know whether how much of the posterior plate already exists. Then this is the cortical plate and the epinuclear plate which is there. And as you put the viscoelastic, the posterior capsule bulge which was there initially you can see that it becomes concave. And again, if the corneas are hazy and you can't make out whether the PC is intact or not, this helps you to decipher that. And this is intraocular lens insertion. Of course, as far as the IOL insertion is concerned, there's nothing much to it, but IOL is in the bag. And as you put it in the bag, notice that there is a gap between the posterior capsule and the intraocular lens because of the retained viscoelastic. And as this viscoelastic is aspirated, this gap would decrease. And we did a study comparing various intraocular lenses and seeing this gap, how it behaves when these lenses are implanted. So this gap would decrease because the viscoelastic is now out, and you would want the lens to sit right onto the PC. And as you hydrate the wound, you can see that there's a spindle of hydration there, which can be seen in the wound. Now, wound is not anteriorly opposed, but is opposed posteriorly. So such subtle things can be made out here, which you actually cannot see otherwise. And again, notice that anterior part is still open, so you have to put more fluid over there and hydrate it so that both the part which is anterior and posterior, both of them actually close. So again, it helps you to understand the insides of the wound better. Now you notice that there's a small DMD which is present here, which actually you can't make out here because it is too hazy. But if you have the intraop OCT microscope, you can make out, and you know that you have to put air bubble at the end of the surgery. Now there are different situations. For instance, this is a posterior subcapsular cataract, so the capsule is quite intact, and this can be seen on the intraop OCT microscope while you're performing the surgery actually. And when you have a posterior polar cataract, you again can make out whether there is defect or not. Now this is a white cataract and fluid clefts or dark spaces are present. So if you give a nick on the capsule, you know once these dark spaces are put there that the fluid is not going to come out because the intralenticular pressure is not that high. So again, this capsulorhexis is initiated first with the needle and then completed with the help of the forceps. And again, as you do that, the dynamics of the capsule and the underlying lens can be understood better on the intraop OCT microscope. Now, there are other kinds of white cataract which are there like this. There are no fluid clefts which are present, and it's a completely like a dead area. And you know that when this occurs, as soon as you give a nick in the capsule, you can actually see the fluid which is coming out. So this is the blob of the fluid which is coming out from here. And I think, again, it is very useful here. This was a case of capsular distension syndrome where there was a gap between the PC and the intraocular lens. And you'll notice that there's also a phimosis. So this phimosis was actually relieved, and after relieving this phimosis, again the viscoelastic was aspirated, and now the lens is sitting bang on onto the posterior capsule, and the patient had myopia which has now been relieved. So it does help you to see the subtle things. Now again, this is to show you the wave of hydration. Once you do hydrodissection, notice that there is a wave there, and you can see the gap between the posterior part of the nucleus as well as the posterior capsule because of the fluid which is present here uh, in such cases. Now here again, to highlight the same fact, that once you have a posterior polar cataract, you can see that there is a defect which is present, and it helps you to plan your surgery better because you know that this is a defect which is already there. And this is a study that I was talking to you about. We've used this for posterior polar cataracts, defined the various type of posterior polar cataracts based on the intraop OCT microscope, and this is a sign which was described by Ron Hugh, which is called as the scroll sign. So once you have a posterior capsular tear, such as in this case, there was a posterior capsular tear which was present here. So the PC actually scrolls, and this is called as the scroll sign. So when you focus on this, look at the scroll of the posterior capsule that you can see here. And once you have this scroll, that means there is a posterior capsule tear. And again, this helps you to plan your surgery better. So this is the scroll which you can see here. So PC will scroll like this downwards, and anterior capsule on intraop OCT will scroll upwards, and we've called it butterfly antenna sign. So this is a scroll sign for PC and a butterfly antenna sign for the anterior part of the capsule. Now, if you've done surgeries like this, this is a case of tuck-in lamellar keratoplasty for which cataract surgery is being done, and you can actually see the dynamics of the graft. And as the graft moves, again, that can be made out. Notice that in this case, this is a tuck-in lamellar keratoplasty. The graft is moved out a little bit over here as you put the intraocular lens. So again, it helps you to titrate your things better. It's still detached here, and then you have to drain out the fluid which is between the graft and the graft and the overlying cornea, and then put a air bubble there. So the graft which was detached now has become attached. So these dynamics you are able to appreciate better. This was a case of post-penetrating keratoplasty, post-DSEC cataract. So for a PK, DSEC was done. You can see that the DSEC graft is sitting here. And after this, the cataract surgery was done. So all the dynamics of the graft as it behaves while the cataract surgery maneuvers are being done can be actually highlighted here. You can see the PK graft wound here, and the posterior, this is the DSEC graft or the lenticule with stroma and endothelium. So as you do the surgery, again, you can make out whether the graft is getting detached or not very well in your intraop OCT microscope. And again, towards the end, you see that there is a little bit of movement of this DSEC graft, which again can be highlighted very well on the intraop OCT microscope. And then you know that you would have to put in an air bubble there so that this graft doesn't detach in the post-operative period. Again, for various desmatopexies, when you have a desmet membrane detachment such as this, you put the air bubble and you think you're done, but actually you're not done because there's still some gap which is present, which can be seen on the intraop OCT microscope. But as you push that air for good 4 to 5 minutes and do external massage, you see this becomes clear. Even if you don't have the intraop OCT microscope, you can make out the anterior part becomes clear, and that is the end point when you know that your Descemet's membrane has become attached, as you can see it here. So it does help you to fine tune your things. And this is my last video. This was something which I called autodemic. This is what something happened. This is just simulated. What actually happened was that the whole Descemet's membrane, when the surgeon was doing phacoemulsification, just came out like this. The surgeon pushed the Descemet's membrane back and sent it to us, and this is 2 hours after the surgeon actually had done the surgery. So we saw that the whole disc was detached, and this is of the own patient. So I call it DMEC. So all we did was see that the biceps scroll upwards configuration, which means the endothelium is looking down and got that disc to attach. So this is our survey of ophthalmology publication on IOCT guided surgeries, especially for anterior segment. So to conclude, intraop OCT helps to refine the steps in phacoemulsification surgery. It does help you to see the unseen and helps you to understand the intraoperative dynamics better during phacoemulsification. Not that you need it, but it just refines your surgery. I would like to invite all of you on behalf of All India Ophthalmological Society to the Asia Pacific Academy of Ophthalmology, which will be held between 3rd to 6th April 2025 in New Delhi. in Yashobhumi, which is the Asia's largest convention center. I hope to see you over there. And thank you very much for your kind attention.